Our next speaker and the final speaker for the morning before we get into some Q&A, and it's just a terrific flow from the fanciful and futuristic to the practical and pragmatic this morning. And there's no one better to take us there on the pragmatic than good Professor Taylor. Spence Taylor is a legendary character from down south in South Carolina. He went to Clemson, where the P is pronounced, but it's not actually, I think it's implied, and has the founding dean or founding associate dean and executive vice president and czar at the Greenville Medical Center Medical College, where he's doing wonderful things in terms of training and faculty development. Will you please help me welcome just a longtime friend of DEFCON to talk about what matters, determinants of functional outcomes, Spence Taylor.
Thank you, David. I am from South Carolina. I did go to Clemson, P implied, but I'm not a legend. But thank you for that terrific introduction. And thanks again for the invitation, David and George. This is a real highlight and a real thrill to come back and see friends and be part of this outstanding symposium. So my task, so you hear about Debbie Downer, the person on Saturday Night Live that sort of brings everybody back to reality. That unfortunately might be a little bit be my role in this, and I'm going to talk about what matters most, determinants of functional outcome. I really have no disclosures. Nobody pays me anything for anything. This is more about expert opinion. I'll give you, there's a heavy dose of my sort of philosophy and thought through this. And what do they say about expert opinion is probably just above Mad Magazine in terms of expertise. But do know that I acknowledge that you'll see sort of my thinking throughout this. Because it really is a 25-year perspective on lower extremity peripheral arterial disease, and it's that perspective started for me with Joe Mills. Joe was a great mentor and friend. He's a couple of years older than me. He was in the Air Force. I was at Baylor College of Medicine, where I came to the Air Force thinking I knew how to do a thoracoabdominal aortic aneurysm, so I'm going to do a ton of thoracoabdominal aortic aneurysms. And Joe taught me the art of lower extremity arterial disease. And then George Andrews. George Andrews, great admiration, because George is a everyday surgeon that basically worked and kept score and published results. So through the years, I've always admired George as being somebody that's real world, but had a scholarly attachment and always looked after his scholarly side of things. If you look at the big Baylor-trained surgeon from Texas, when I went back home to South Carolina, there weren't a lot of thoracoabdominal aortic aneurysms. In reality, there were more lower extremity arterial disease cases, so I went from being the thoracoabdominal aortic aneurysm surgeon to lower extremity arterial surgeon. And also, hopefully, like George Andrews, I kept score. I did a fairly good job of keeping the score and outcomes from all the patients we took care of in Greenville, and published a lot of papers around lower extremity arterial disease. Two really good mentors in Joe Mills and George Andrews, and thanks for the invitation to be back. This is a case I've told in this forum before, but it's a great case, and it had a huge impact on the way that I deal with things. And if you were in the conference yesterday, you saw some of those incredible limbs that Joe Mills and I saved in the Air Force, and I mean, these awful limbs. It was basically half cut off feet that we were able to get better. So when I went to Greenville, South Carolina, I was a hot shot, arrogant young surgeon that could take care of any foot. You send me anything within a 200-mile radius, and I'll save that foot because I'm better than anybody in the state of South Carolina. That was sort of my philosophy, all right? So they said, all right, big boy, here we got one for you. There's a lady in Miss C, and she's a 70-year-old lady. She's over here at Clemson and Oconee Hospital, and we're going to send her over here. She was perfectly functional, was cooking Sunday dinner up until she got a little foot sore. She got a little CHF, got some blisters on her foot, and we really think that we ought to send her to you because you're such a big shot and you can fix this leg. So this was her leg. This is this fixed picture over the left, a couple of blisters. She had exposed fibula. She had punched out lesions of her toe. She had osteomyelitis. And I looked at it and said, well, this is no different, Joe, and I fix these people all the time in the Air Force, which we did. I went ahead and did an arteriogram. I did a femoral to posterior tibial artery bypass, take it off the profunda because it didn't have great vein length, but everything looked great. I drilled holes in her fibula. We had wound care. I put her on hyperbaric oxygen. We did everything but shake gourds over her bedside. We got her wound to granulate. We put skin grafts on her, sent her to the rehab hospital. She was there for about 6 weeks. Went home, and then basically the first meeting she was her first office visit, she was supposed to come back and see me. She didn't show. And so I got a nurse to call. I said, well, what happened to Miss C? And they said, oh, we forgot to tell you. She died the night she came home from the rehab hospital. But tell Dr. Taylor we really liked him and he did a great job. So that was really a terrific thought, and I felt really good about that. And the thing that struck me about this case was that a successful outcome? And the issue is this. If you'd have looked at the time, the stuff that we were measuring, your patency rates, your limb salvage rates, 30-day mortality, she met every single one of them. She died with her boots on. She died with an open bypass. She had a healed extremity. I would have been an A+, check every box. But in reality, did we really help her? And the question that it sent me on is, do we need to change our approach to the management of critical limb ischemia? A real journey that this sort of kicked me off on. So what we did is we went to our registry and looked at, this was one of the early studies that we did with just basically this Mrs. C in mind. And we looked at determinants of functional outcome after revascularization for critical limb ischemia. We looked at 1,000 cases that we did, a mixture of endovascular and open cases. And we really looked at basically, could we have predicted Mrs. C's case a little bit better by looking at her pre-op? I mean, in retrospect, I look at that foot and the leg and cooking Sunday dinner, really. Was she really cooking Sunday dinner before she went in? Yes. But at the time, we said, is there ways that we can determine this? In this paper, if you look at it, we actually did pretty well. We were able to keep most of our grafts open. 64% at 5 years were patent. We have 70-some-odd% of our limbs were salvaged at 5 years. And if you look at our mortality, really very shockingly, 42% survival at 5 years. This only to say that this was about as good as anybody was publishing at the time in the mid-2000s. And we were not bad doctors. We were actually getting reasonably good results. But what we found did surprise us. And what we found is the functional outcome was really not predicted solely by these parameters. You could have a patent bypass, you could have a limb, but a lot of these patients, when you look at maintenance of ambulation and maintenance of independent living status, had nothing to do with whether or not you kept their foot on or not. And things like dementia, things like whether they were walking when they came in, things like were they cooking Sunday dinner before they came in, really were things that mattered more probably than things like limb salvage. And so this sort of sent us again towards a philosophy around what the prevailing thought of the time was. Remember, even now, the big debate that we hear more, and it's been going on for 15 years, is what kind of therapy. If you can just find the right therapy, the right balloon, the drug-eluting balloon, if we can find the right therapy, you're going to basically be able to fix the problem, and you're going to be able to make people well. And the problem is we basically take that therapy and we hit it towards the average patient. So there's a targeted at the average patient. But the question is, we just assume that all patients are average patients. And there's this acknowledgement that there's some patients that are better than average, and there's some patients that are worse than average. And the question is, what do you do with these patients that are the outliers? What do you do with these patients that are the outliers? So that's the big question as you go forward. So if you look at our paper that looked at 1,000 consecutive patients, we noticed this. There were independent predictors of poor outcome that were beyond what we talked about as far as traditional parameters. They were things like coronary artery disease, diabetes, end-stage renal disease, gangrene, and dementia. These were all independent predictors of bad outcome. So how do you, if you look at this and you thought about, well, if you just don't treat any of those people, you're going to get a good outcome, or I could prevent Mrs. C? And the answer is no. But when you look at this group, it's interesting to say, what if you look at claudication, rest pain, and tissue loss, it's amazing. Each of these basic diseases, these presentations, are packets of disease that have these factors in it. So people with claudication have less of these risk factors than people with rest pain, who have less of these risk factors than people with tissue loss. So this put us on the next paper. We looked at 2,200 consecutive limb revascularization we did and presented this at the Southern Surgical Association, and looked, if you can see from this, it was about evenly. It was about half of our folks were in claudicants and half of them were critical limb ischemia, a little more critical limb ischemia. We're an endovascular shop, and 60% of these cases were treated with endovascular, 40% with open surgery. But when you looked at the outcomes of these, this is exactly what we found, that these presentations, whether it's claudication, rest pain, or critical limb ischemia, were incredible predictors of outcome for things like secondary patency, amputation-free survival, maintenance of ambulation, maintenance of independent living status. These actually predict the outcomes. And so the implication of this is it really doesn't matter how you treat these people, whether it's open or endo, at least to us, this is our interpretation. The outcomes of these patients, if they're really going to get up and at them and return to life, are based on the intrinsic comorbidities at presentation. It really doesn't matter how you treat them. So it's not who to treat, not how to treat. It's about the leg, and it's not about the leg, it's about the patient. So that's sort of the takeaway from this. Now, the other takeaway is this: is if you look at amputation-free survival in patients that are critical with tissue loss, they had a 25% 5-year amputation-free survival rate. That is as bad as any pancreatic cancer, any gastric, any kind of cancer that you're going to see. These are really, really sick patients. And so the issue that you kind of look at is, what are you going to do? You realize that people are going to go to heaven whether you operate on them or not, and the question is when do you throw the towel in? And this whole issue is you basically can't target therapy to the outliers. Who are the outliers as you go forward? Clearly, the people with critical limb ischemia are the outliers. So this is a great case of a lady that's 93 years old. She's an outlier. She's mentally sharp. She'd had a prior angioplasty of her leg before. She lives in the nursing home, the old folks home up on Augusta Road in Greenville. She's functionally independent. She can use her legs to transfer the wheelchair to the commode and back to the bed again, but spends most of her time in a wheelchair. Has a little congestive failure. She's diabetes. And she presents with gangrenous changes to the second toe. And this is what it looks like. And it looks pretty innocuous, but you could take a probe, which we did, and you can put it in the top of that wound, and it comes out on the bottom of that wound, which is not a good thing at all. She had a slight left knee contracture. Again, she transfers, but really doesn't walk, but she gets around to get on the commode, etc. Her ankle brachial index was 0.39. Her toe pressure was 13. If we'd have done some of the other flow measurements that Dr. Mills showed us, I suspect they would have shown similar. She had triphasic common femoral waveform. She superficial femoral artery was definitely occluded. It was reconstitution of the tibial vessels of the mid-shank. And so she has osteomyelitis. And the question is, what do you do? Well, the solution's simple because we treat to the average. You basically revasculate because that's what you do for patients with critical limb ischemia, right? That's what you do. That's what you do. You treat to the average. She's an outlier. So what do you do? All right, so David Cole and I and John York got together and said, let's figure out a better way to look at this. And let's try to use a consumer report guide at looking at outcomes a little bit differently. And what if we said, if you were a patient and you said, I got a bad toe and this is what I would achieve, this is what I want out of success, we came up with these 4 parameters. We said the following, that a successful outcome, if I was a consumer, would be graft patency to the point of wound healing. That means if the graft patency or the interventional patency went down and it healed anyway, you didn't need the intervention to start with, right? Or if the thing poops out before the thing heals, that's a failure. That's what I'd want as a consumer. I'd want to be able to say limb salvage for 1 year is a minimum. That's my guarantee would have that in. Maintenance of ambulatory status for 1 year and survival for at least 6 months. That's code for the operation didn't kill me, right? That's what that's code for. So we tested this. We said, all right, what if you were successful, we can achieve all of these. Let's test it on 607 patients with peripheral arterial disease and critical limb ischemia and ulcerations and see what else. So we did it it was evenly distributed between endo and open. And this is what we found. Overall success of achieving all of those objectives, almost 41%. That was it. Open bypass endovascular really didn't make a big difference. And then we did multivariate analysis on it. We found these independent predictors. And this is it. If you have impaired ambulatory status at the time you walk in, if you have end-stage renal disease, diabetes, presence of gangrene or prior vascular intervention, these were all independent predictors of not achieving success. These are if you want to write anything down, this is the takeaway points in my book. So we looked at this, and we looked at probability of success and failure. So if you have no predictors, none of those predictors, your chance of success is almost 70%. That's basically being able to get well, and get walking. However, if you have 3 of those, your success drops rapidly down to 20%, and if you have all 5 of those predictors, your chance of success is less than 10%, with the probability of failure 92.8% chance of success. So the naysayers around here, everybody goes, but you got to do something. I mean, what are you going to do? You got to do something. When I say you cut the leg off, maybe put them into wound hospice. But no, most people say, well, you got to, what's the harm in doing endovascular therapy? You're not going to hurt anybody. The lady doesn't have renal failure. You can put a balloon up. It's not a big deal. Just give it a try. Just put the balloon up and say it's well tolerated. It's that yada, 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 yada. Well, the problem is this, and this is the Medicare allowable 2014. This isn't cost. This isn't charges. These are real dollars. These are the dollars that come right out of the taxpayer till. This is the reimbursable in the state of South Carolina. Every time you blow up a balloon in the superficial femoral artery, $12,000 of taxpayer money goes to that hospital to offset the cost of that procedure. That's real dollars, your dollars, everybody's dollars. And listen, I am all for those dollars going to the hospital if it's going to help the patient. But if it's not going to help the patient, that's $12,000 that can go to something else. $12,000 is what it basically is. So the issue is that it's the cost. And so our theory is, our story was that David Culler and I, when we looked at this, that this was going on all over the state. That in essence, angioplasty people were just saying, well, what the heck? Why don't we can try angioplasty? We did this cute little study. I thought this was pretty cool. David really did most of the work on this, and he looked at the South Carolina Office of Record and Statistics database, which is a pretty cool database. And our hypothesis was that the number of endovascular procedures has increased for lower extremity arterial disease over a 10-year period of time because we can do it now, and got excited about doing it. And there was a lot of Mrs. H's out there. That was our first story. And the second story is that really weren't making a huge difference. And so he did this study looking at the SCORES database. And he looked at 1996, which he called the open era, when most of the bypasses were done open, and the endovascular in 2075. And what he found was, and presented this at the Southern Surgical Association as well in 2009, is that indeed the number of procedures is up about 30%. And, indeed, more times than not, that more people were doing angioplasty as opposed to open surgery. Went from 75-25 to 50-50. But the findings were, and our hypothesis was confirmed, the number of secondary revascularizations doubled from 8 to 9% over the time period, meaning that when you angioplasty them, it probably didn't have the durability that it had. And then secondly, the amputation rate was not improved. A staggering 50% at 3 years in the state of South Carolina. So, in essence, we made this conclusion that our shift from open to endovascular surgery, while less invasive, has increased the amount of care at about $12,000 every time you blow the balloon up without improving outcomes. All right? So that's sort of a shocking sort of thing. So if you look at our case, Mrs. H, and you look at her and say, what are my chances? Now, in the old-fashioned world, I would have come in and said, Mrs. H, we're going to get this bypass. You're going to do terrific. You have a 70 to 80% chance of success, because I can give you patency data that shows that in my hands I can get you this, and I can save your limb in 80% of the cases. But in reality, if you're going to look at success the way we looked at success, your bypass stays open to the point of wound healing. You're able to walk for a year. You're able to live for 6 months, and your graft actually stays open for a year, or you ambulate for a year. Her chances were really about 10 to 20%. Because she had all the findings known there. So that's a real helpful tool. So if these people have the predictors that we said, this was it. And it goes back to this. This is the philosophy that we've had. You know, we focus on, there's an old patient, and you basically, you know, if we can fix the leg, it's going to be all right. It's sort of like the pilot says, this is crazy, Captain. I fixed the altimeter twice, and for some reason it still says we're losing altitude. And we just got to understand that there's some patients that are losing altitude. All right? Some patients are losing altitude. One final thought. This was a paper that we put together and presented at the Southern Vascular last year, and it came back from this sort of arrogance of us saying, well, we know what the patient wants. The patient wants to bypass stay open until the wound heals, wants to walk for a year, and patiency for a year. But in reality, we don't really know what patients want. We don't know what they want. So we said, why don't we ask them? Kind of a novel thought, right? So we got our research nurses on this, and we looked at 102 patients undergoing elective surgery and said, if you have a perfect outcome and you want, you know, for this procedure that Dr. Taylor is getting ready to do for you, what would be that procedure? Well, I was shocked to find out that 66% of them really don't know. They just said, well, Dr. Taylor said, I need to have this operation, so I'm going to have the operation. That was a little bit sobering, a little bit of a wake-up call. That was only 66% of them felt that. But the ones that you could really drill down to, they said a successful outcome would be one of the following. 82% said that we would think would be success if I never had to return to the doctor. He fixed the problem and it went away. This translated is nobody wants to have a great relationship with their auto mechanic, right? Nobody wants to say that I want to come back and bring my car in for the broken transmission every week. Well, patients are no different. They have a problem, they want it fixed and move on. They want maintenance of daily activity, maintenance of mobility, relief of pain was a biggie. Continue hobbies, and only 12% continue to work because only about 12% of the patients we take care of work. So that's, no, I'm just kidding, but that was sort of low on the list. So we constructed a very similar model. We said, all right, if you were able to achieve these 5 things, which the patients asked for, how successful would critical limb ischemia treatment be in our practice in Greenville, South Carolina? In other words, how many of the patients would have maintenance of independent living, maintenance of ambulatory status, control or relief of pain, no additional routine physician visits, and survival at 1 year? Well, the answer to that, when you put it all together, 23%. Only 23% had a successful outcome according to what they said. And if you looked at independent predictors, we had if you have end-stage renal disease, impaired ambulatory status, our old friend impaired ambulatory status, that's a biggie. If you have impaired ambulatory status, you're not really going to, in our hands, you don't really make a lot of advances. These are independent predictors of failure. And then these were the numbers that we basically ran. If you have no comorbidities, your chance of being successful is only 73%. So all in all, the lessons we learned from this study is that patient-centered expectation outcomes after intervention for CLI are unique and distinctly different from the currents that are being measured right now. And then when you look in aggregate, we don't do a very good job. Now, we sent this paper to the Journal of Vascular Surgery. It was amazing. I remember submitting it electronically. I think I went to get a cup of coffee, and when I got back to my desk, they had rejected it. It was the fastest rejection I'd ever had. Unbelievable. So we try to reason with these people. We can't get this published. It's a terrible mess. I mean, Joe Mills said yesterday, well, Dr. Taylor's done a lot of stuff on looking at functional outcomes, but everybody seems to ignore it. And it's just a tough message. This is a really, really hard message to muster and accept. I know that the guys at Wake Forest did almost an identical study to this year at the Southern Vascular, came up with almost identical results. Only about 30% of their patients got patient-centered outcomes or achieved patient-centered outcomes. And I'm anxious to see if they have any better luck. It was a little better study, so I'm anxious to see if it gets published, and I think it really ought to. So in essence, in summary, peripheral arterial disease is an incurable systemic disease. We're not as good as we think we are. Don't kid yourself. Treatment is palliative, guys. This is palliative therapy. The real outcomes depend on who's keeping score. If you're keeping score, you're going to have different outcomes than if the patient's keeping score, if the payer's keeping score, right? And I think the future is if we can define effective care through targeted outcomes, patient-centered outcomes, that's going to be the ticket. And then the final message that what everybody needs to learn, and this goes back to with Mrs. C and Mrs. H, just remember, human life is a sexually transmitted disease with 100% mortality. You can't fix a systemic problem with local operation. Thank you very much.